Here's another finding. This is one we would consider to be purely hyperechoic, and this is a patient that had just a palpable ridge of normal fibroglandular tissue. We would not be concerned with that. If a patient presents with a palpable abnormality, and this person came in feeling that abnormality, we could see that it was just this ridge of normal fibroglandular tissue. Now, anytime we're going to tell a patient that something is normal tissue, what we recommend is that they check that area once a month. We told her to go back and have her clinician recheck this area in 6 months if anything was to change, to have it reevaluated. Well, the patient came back to our department 4 months later, and we can see kind of within this gray area here, which nobody could really make out a mass at the time, this high-grade invasive ductal carcinoma kind of exploded that she had not felt previously. So these high-grade lesions are very rapidly growing. Very important that if somebody's going to follow up what you think is normal tissue, that they check that area at least once a month. Now, when we look at ultrasound and we're comparing it to things on the mammogram, we want to make sure that the size, shape, location, and surrounding tissue all match up. This lesion here was a 13 millimeter mammographic nodule. We expect maybe a little bit of measurement error when we're comparing mammography to sonography, but they should be pretty much the same. You can see we have almost a 50% difference in that, so our size was not matching up. Going back in and rechecking this particular patient, what had happened was the technologist had done a scan more through this area of the tissue, creating this area of echogenicity, and actually had missed these two small cancers sitting on top of each other, and just sort of mistook this thick echogenic halo as being the mammographic nodule. But your size, shape, location, surrounding tissue should all match up. If you have something that's 13 millimeters on the mammogram, it should be pretty much the same size when you do the ultrasound. Looking at elliptical shape for our benign finding, it'd be wonderful if all fibroadenomas look like this, but we know that they don't. They tend to be more wider than tall or elliptical shape, and almost looks like a little almond sitting in there. But this is a classic fibroadenoma. We will allow up to 2 to 3 gentle lobulations of fibroadenomas. One other thing we want to make sure is that there is a nice thin capsule completely surrounding it, so these are gently lobulated fibroadenomas, and that is okay for calling it a BI-RADS3, that means probably benign. One other feature that we'll allow for is what's called a teardrop shape, where you've got one edge of the fibroadenoma that comes to just a little point. We don't consider this to be an angular margin, but more of a teardrop shaped fibroadenoma, and that is something that we will allow for in calling fibroadenomas. As already mentioned, we want to make sure that either elliptical or gently lobulated structure also has a thin echogenic pseudocapsule surrounding it. If you have compound imaging, it makes it much easier to be able to see these thin echogenic capsules. If the capsule is surrounded by echogenic fibroglandular tissue, it's a little bit more difficult to see the thin capsule surrounding that. So much easier to see it if we are scanning against a fatty background. Just the normal scan pressure of your hand resting on the breast tissue sometimes is enough to compress that fibroglandular tissue up against the capsule. So what I'll do real time is lighten up my pressure, and you can see by scanning with lighter pressure we're able to actually see the capsule a lot better than we could with our normal scan pressure here. So in looking at that, another thing to be aware of, once you lighten up your pressure to see the capsule better, you may cause some artifactual shadowing. And remember, shadowing is a feature worrisome for malignancy. So in real time, it's just one thing you want to do is scan with normal pressure and lighten your pressure to be able to see the capsule a little bit better. So you will need a combination of both heavy and light scanning plane. The other thing is making sure that the capsule is complete all the way around the ends of a lesion. You can see on this fibroadenoma here, we can see the capsule very well on the anterior and posterior surface, but we don't see it very well on the ends of the lesion. So coming in and healing from this end, you can see the capsule extending all the way around. Towing from the other end, we can see the capsule coming around that way. Is this something I take pictures of? No, it's just something that I'll make sure I do when scanning lesions real time. Any solid nodule that we have in our department, our radiologist comes back in the room and talks to the patient. So either I'll scan and show them this during real time, or something that if they're scanning, they'll make sure that they can see the capsule extend all the way around the lesion. I was in a lecture once at the RSNA, and I heard this physician get up and present a paper and say, well, according to Stavros's criteria, this is a benign lesion because there's a thin echogenic pseudocapsule. There is a thin capsule, but this is obviously not a benign lesion. There's microlobulations, it's very heterogeneous. If we put on color Doppler, you would see all kinds of flow within this. This is a high-grade lesion. High-grade lesions are very rapidly growing, and we would expect to see a thin echogenic capsule. If you look here on the specimen, you can see how thin the capsule will be because those high-grade lesions grow very rapidly. They are pushing their way through the tissue, so anytime you see a thin echogenic capsule, don't always assume the lesion is benign. A lot of things, you want to make sure there are no other features worrisome for malignancy that we'll see such in this particular lesion. Looking at our negative predictive value, we have never seen a purely hyperechoic cancer. Now, I'd say about once a year we'd get a case that would come in something like this, would be sent in to Dr. Stavros, and they would say, look, this is a purely hyperechoic cancer, but is it? Look in the center. There is a 2 millimeter hypoechoic central portion that we can see, and then what we're noticing is just this thick echogenic halo surrounding the lesion. Now, one thing that might happen is you have a patient that presents something like this. This is a palpable lump. You might think that this is just normal fibroglandular tissue right here, but this is 1 centimeter across here. We want to get this closer to the elevation plane focus where our transducer is focused. So when we do that, we want to use a standoff pad. You can notice that once we use a standoff pad, you can see these 2 small hypoechoic cancers in this area of the thick echogenic halo, that we got some volume averaging through here. So be sure that you optimize your image completely. If anything is within that 1st centimeter of the transducer, use a standoff pad or a big glop of gel to make sure that you get the lesion closer to the elevation plane focus, that you don't get volume averaging, calling something purely hyperechoic tissue. Now, once I've seen a suspicious lesion in the breast, what I want to do is check the axilla. I want to look at lymph nodes and see if there's anything suspicious in the axilla. A normal lymph node looks just like a kidney. Here we can see in a long axis view and a short axis view. These were zoomed up pretty large, but it looks just like a kidney. This would be our parenchyma or the cortex and our fatty central hilum. This is a transverse view that we can see that coming around. One question I get is, we know that the center of a lymph node is fat. Why is the fat on a lymph node more echogenic compared to normal fat? And what it is the lymphatic channels running through that cause the fatty hilum to be more echogenic. Now, there's a variation of normal that we can see within lymph nodes. We can have the perfectly normal lymph node. We can start to get thinning of the cortex, just like what we'll see with kidneys. And at times we may actually get fatty infiltration into a lymph node. So here you can see this is the cortex. This is the lymphatic portion of the fat that is more echogenic, and this is fatty infiltration that we see within this lymph node. This is perfectly normal. The only time we get more concerned about lymph nodes is when the cortex itself is thick. We're going to talk about lymphatic flow. This is not the blood flow, but this is how the lymphatic system will flow. It's from the subcapsular sinusoids to the cortical sinusoids and into the medullary. So lymphatic flow is going to start from the outside of the lymph node and move in centrally. And if we look at a foreign body, it affects a lymph node differently. Foreign bodies are going to be from the medullary sinusoids out. So if you have a patient that had a silicone implant that ruptured, these are silicone granulomas within a lymph node. Here you can see the cortex right there is that tiny little hypoechoic line. Whereas when we have a tumor, metastasis to a lymph node, that affects from the outside of the lymph node going in. So the cortex is what will be thickened. So the opposite for a foreign body versus metastasis. Foreign bodies are from medullary sinusoids out. Metastases are from the cortical sinusoids coming in. Now, there's a range of abnormal sonographic appearances that we'll see with a lymph node. In the center, we have a perfectly normal lymph node. Then what we will notice is that sometimes you might see a lymph node where just the cortex is thickened all the way around. You may have it where you see just portions of the cortex being thickened or abnormal. You may have a lymph node that looks like there was a rat bite taken out of it. Maybe you may have ones where the cortex gets so thick that it compresses the fatty hilum centrally. You may have it where it compresses the fatty hilum to the outside of the lymph node. Sometimes you may have a lymph node that just looks grossly abnormal, almost like a round ball. And at times, some lymph nodes may even become very ragged and jagged and actually look just like a metastatic lesion itself. Now beware, any of these types of appearances, either this lymph node, or this one, can go along with either metastasis or it could be an inflammatory process. But if you're scanning the patient doing a breast ultrasound, you see a suspicious lesion in the breast, then you go scan the axilla, most likely you're dealing with a metastatic lymph node. Sometimes we are asked to scan a patient because they present with a palpable abnormality in the axilla. If that's the case and you see the appearance of any of these types of lymph nodes, the patient definitely needs to have a breast workup to make sure that there is not a breast lesion causing it. But if you see multiple abnormal lymph nodes, it possibly could be an inflammatory process and not a metastatic if you start looking in the axilla to begin with. Now, one thing that we have found is anytime we see a grossly abnormal lymph node sitting next to a normal lymph node, that's pretty much a malignant lymph node. Here's another example. Here's a grossly abnormal lymph node sitting right next to a normal lymph node. And another one, grossly abnormal lymph node sitting next to one that's probably a little bit too thick within that cortex. So this is also an abnormal lymph node. But if you have metastasis, you may find this type of pattern. If you have an inflammatory condition or inflammation, typically that's going to affect the whole range or the whole region of lymph nodes in that and not just one. So if you see one abnormal next to a normal, that will typically be a metastatic lymph node. What we'll do on the case if we do see these lymph nodes, we will go ahead and biopsy them. If it's proven to be a metastatic lymph node, then the patient does not need to go for a sentinel node procedure. They can go straight to an axillary dissection. So seeing these types of abnormal lymph nodes can be very helpful. But once you guys all understand breast sonography, you'll love it, and watch out for those speed humps. Thank you.